Hi everyone, this is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth, your favorite website to educate you on human heart and its illnesses. I thank you for your continued and enthusiastic interest and support in my cause of spreading this bit of education freely to all. Thanks again. In this video vignette, very briefly, I want to talk to you about what is myocardial viability. As you see it here, it has a connotation where one defines that some bit of myocardium is viable even though it is assumed that it may not be. So we need to ascertain whether that portion of the myocardium, which is the region of the heart muscle cell within the suspected area, which possibly the thinking was that may have suffered a permanent damage, is still viable. And that's where the interest in cardiologists and nuclear cardiologists is. It's a very, very intriguing subject. Just like we talked about vulnerable plaques on a previous video vignette. If you have visited, if not, please do. But similarly here, myocardial viability is a very, very intriguing subject. So one, we have to demonstrate that there is a decreased blood supply to the region. Two, we have to demonstrate that there is a preservation of this myocardial cell wall, because the myocardial or the heart cell wall has to be preserved. And in order to have that preservation, then you can talk about the intracellular metabolic activity of that cell. So three things. One, obviously you have to demonstrate that there is a decreased blood supply to the region. Two, you have to show that the individual myocardial cell, which is microscopic, remember, and that microscopic cell membrane is preserved. And three, you have to show that intracellular function, the machinery of the cell, the mechanics of the cell is functional, even though it may be functioning at a slower pace, so-called the hibernation we all went through in this winter. Okay, so similarly, the cell also hibernates. We call it stunning or hibernation. A stunning is normally occurring at a time when there is an acute lack of blood supply, acute decrease in blood supply to any particular wall or region. Whereas chronically suppressed myocardial perfusion, that means, in other words, over a long period of time, there has been a decreased blood supply to some portion of that heart muscle. That is called hibernation. So hibernating myocardium and stunning myocardium can both be seen within that segment which has been shown or suspected to be dysfunctional on an echo or whatever study that the originally the patient had. Or there is a suspicion that patient is a heart failure, for instance, and we know that that portion of the ventricle is not working too well. So it's very important that we need to ascertain, can something be done about it? Okay, that's a common question. What can we do to save the myocardium or the heart muscle from deteriorating? One. And two, what can we do to reverse the disease that is already in there, if we can, by any method of revascularization or what have you. So a temporal improvement of contractile function is in a dysfunctional region after myocardial perfusion is restored is called myocardial viability. And I just defined those three areas. I know it's pretty intense here, but this is mainly for cardiology fellows and internists and doctors like me who are wanting to sort of quickly brush up and either taking the exams, the recertifications, or even the nursing staff in nuclear or cardiologists in nuclear areas, training, etc., who would like to know how we proceed in nuclear labs if we are questioning myocardial viability in a patient. Having said that, let's understand you need a radio tracer, a radioisotope, which will tag and identify the perfusion capacity, the integrity of the myocardial cell, and a metabolism as well. So here we go. We need a tracer which can show all three. Unfortunately, we don't have one tracer yet, but that'll be the ideal choice. If we can demonstrate all three properties of that cell, of that region, then that's a done deal. But we don't have that yet. But we can use two tracers. And one of the tracers is obviously technetium-99. I've shown you here in this panel, right? Likewise here. And then the other tracer is the fluoro-18 deoxyglucose, we call it FTG-18. Now this is a metabolic tracer, and this is a perfusion and integrity tracer, remember that. So technetium-99 will be used for perfusion and integrity of the cell, and FTG is being used for mainly as a tracer for metabolism. A mismatch, remember, now when during the stress you take a picture and you take the resting pictures, and say if you found that the infralateral, this is the inferior and that's the lateral view, the tracer did not go in. That shows that the perfusion was deficient in this region. It was deficient in this region, deficient in these various sections of the heart. So as a result, what happens is this area is utilizing only glucose, whereas in a fasting state, normally you would utilize free fatty acids. The myocardium will require to utilize free fatty acids. So if this was only utilizing glucose, what you do is now you inject FTG-18 and immediately you'll see an uptake, because this myocardium, if it is viable, will show an uptake of the FTG-18 here. And that'll show a mismatch. In other words, a mismatch confirms myocardial viability to a great extent, and therefore one can do and offer a revascularization to this patient. Why? Because you have shown that there is a perfusion which is lacking and there is metabolism that is existing. So the segments are viable, and therefore you can see a mismatch here, as because this area which was not lighting up shows up very well lit up here in the FTG scintigram, if you will. Now take the other example where you have no perfusion in this area, no perfusion in this area based on the technetium-99, and obviously the sarcolemma integrity has been also not preserved. What happens to the F18 when you do the tracer study, the tracer scintigram? Very minimal or none. Very minimal or none. So this is a match. Here we have a match where nothing really goes into the F18 scintigram in terms of uptake, or minimally. So this is again dual isotope acquisition. We call it DISA. And when we have dual isotope acquisitions, one can ascertain that if there is a match, one should not send that person for revascularization. And that's a commonly asked board question, guys. So make sure you understand this very well. So where there is a match, if you see a match, do not send this patient for revascularization, because this patient is not going to benefit anywhere from a PCI or a stent or a CABG. Whereas this patient will benefit, because here I've shown the lateral and the inferior walls, and they seem to really show an increased uptake of FTG, and a myocardial mismatch viability study should go for revascularization. Okay? So an ischemic heart failure can really benefit hugely from this paradigm or treatment approach, and therefore one needs to identify increasingly more heart failure patients as we go forwards in our cardiology world. Stay tuned for more intense work, and obviously I know this is pretty intense, but just so that you know that even for patients, even for laypersons, that radioisotope studies are very, very safe. They have been indicated by a cardiologist for you to go. Certain contraindications, like obviously women from reproductive age cannot go for nuclear studies, but other than that, there is no nobody's allergic to a nuclear radioisotope tracer that we know of in the cardiology area, and we have been using it for over 40 years now. These are absolute safe techniques, and minimal radiations are being offered just as a layperson, and the whole study may take only about half a day. You don't have to be admitted. Patient's going to the hospital, comes out the same afternoon, and with a result in his hand or her hand, clearly telling whether the patient should go for revascularization. Like whenever the question is whether this patient can go for a bypass or a stent placement, nuclear myocardial viability study is the way to go, which will answer these questions. There are other isotopes like thallium also being utilized for myocardial viability, just for the sake of the residents and fellows. There's so much information to be shared, but I'm sure I'm going to save that for the next video. Okay? Thanks for watching my website, MuniMeterHealth.com, on Facebook and YouTube. I again support I'm very, very grateful for your support and your enthusiastic interest. Thanks.